what criteria we're using today and if the CDC is updating that criteria. And then the second component is, our testing capabilities seem a bit too slow at this juncture, and I'd be curious to hear what we're doing to increase the rapidity and availability of tests.
The recommendation should be when a clinician or a public health individual suspects coronavirus, then we should be able to get a test for coronavirus. So that's the current guidance that went out today. And this is a fluid situation. And your second question is also critical. How do we expand the availability of testing? We think it was an accomplishment to, within a week, to develop a test so we could get eyes on this, and I think the CDC scientists were able to do that. But that was not to take away the broader responsibility for the private sector to come in to be able to provide broader testing for the non-public health community.
Dr. Redfield, how can the virus be both a problem that's going away and also not a question of if, but when? What should we be telling our constituents about what to expect?
Right now at this stage, and I've said this and I continue to say it, the risk to the American public is low. We have an aggressive containment strategy that really has worked up to this time, 15 cases in the United States. Until the case that we just had in Sacramento, we hadn't had a new case in 2 weeks. We do believe we're going to continue to see new cases, and we do believe now there may be the initial cluster or occurrence of a community. There's a lot we don't know, and we're learning more each day. That's what concerns those of us that are confronting this. If it was flu, we understand flu. But there's a lot we don't know. But what we have learned in the last 8 weeks is that this virus can actually cause asymptomatic infection. No symptoms. Now that's complicated when you're dealing with a public health threat.